Now, I'd like to welcome our presenters for today's workshop, Dr. Dan Hale, Dennis Antoine, and Kimberly Monson. Thank you so much for joining us today. Over to you.
Thank you. It's great to be here with you today. So good morning, everyone. You've heard a little bit of an introduction. I'll say a little bit more. So I'm Dr. Dan Hale. I'm a clinical psychologist working at Johns Hopkins Bayview Medical Center. And joining me on our presentation today, will be Dr. Dennis Antoine, psychiatrist, assistant professor of psychiatry and behavioral sciences, also at Bayview, and Kimberly Monson, who is our community programs coordinator. And we're very pleased to have the opportunity to share with you today some information about this Congregational Depression Awareness Program, a program that the three of us developed a little over 2 years ago. Have been very pleased with the results we've seen, the interest shown, and we're excited about the opportunity to share with you. So I'll next illustrate what we'll be covering today. So we'll do a little bit of an introduction, talking about the symptoms of depression, and then some of the treatments and resources, what we've learned, and future directions, and then we'll have time for Q&A. Let me start by saying a few things about depression itself. And we're talking here about more than a depressed mood. We're talking about a condition, a mental health condition, an illness that sometimes is referred to as major depression or clinical depression, which is far more than the sadness that everyone experiences at some point in their life. This type of depression is now recognized as one of our most significant health concerns. According to a major study conducted prior, because this was before COVID-19 pandemic, more than 10% of American adults reported experiencing a major depressive episode during the prior 12 months. And more than 20% reported experiencing at least one episode over their lifetime. And we know that depression does not discriminate. It can affect anyone, regardless of age, gender, race, income, or faith. Furthermore, we know that depression is the major risk factor for suicide, which is now the second leading cause of death in people ages 10 to 34, and the fifth leading cause of death among individuals aged 35 to 54. And studies show that this suicide rate has increased dramatically in recent years, rising 30% from the year 2000 to 2020. Now, while it is clear that depression is a painful and potentially lethal illness, there's good news that needs to be shared. Depression is a treatable condition. Most individuals with appropriate treatment and support can recover from depression. However, far too many people who suffer from depression fail to receive their effective treatments. And what you see here on the slide, these are some of the challenges, some of the obstacles that often interfere with this. So we start by talking about difficulty recognizing symptoms. It may seem odd, but many people who are suffering from depression do not realize that that's what's going on for them. They know that they're hurting, they know that something is wrong, something has changed, but they don't know what it is. So this is the first hurdle we have to help people get over. Recognizing that what they're experiencing could be this type of major or clinical depression. Even if we get them over that hurdle, there's another one that they often encounter, which is the stigma of mental illness. That this is something to acknowledge that they have this illness, that they have this condition, that that's a sign of weakness and that they should be embarrassed or they should be ashamed of it. Or maybe it's because their faith isn't strong enough. There's several things that can sort of block them. So even if they recognize they're depressed, they may not take the step of seeking help. If we get them over those two hurdles, then what you find is when it comes to treatment, often there's pessimism about treatment. In fact, pessimism is right at the heart of depression. So people who are depressed find it very difficult to see hope, to see how they're going to get better. Or sometimes what interferes are misconceptions about treatment, what it would be like, what it would cost. And then finally, there's the difficulty finding affordable professional care, where they often need that sort of help. So for the next few minutes, I'm going to go over the symptoms of major depression. Just take a little bit so we can clarify what it really looks like. So the first symptom we talk about is this depressed mood with overwhelming feelings of sadness, or feeling empty, or feeling numb. And it's pervasive, and it's all consuming almost. In a lot of ways, it feels like grief, which I imagine everyone has experienced. But there are a couple differences from grief. One is that grief tends to come in waves, wash over you and recede and wash over you again. Another is, most time with grief, it doesn't affect how one thinks and feels about themselves. And that's a critical part of this sort of depression, where people really, and we'll get to this in a minute, they really are so self-critical. The next symptom, and I think that this is a very important one to pay attention to, because it sometimes might be the first thing you notice in someone else, or maybe yourself, which is a loss of interest or pleasure in activities previously enjoyed. All right, so maybe, and those could be physical activities, doing exercise, that could be social activities, getting together with friends, that could be worship activities, that could be solitary activities. But when you're depressed, you no longer have that ability to really enjoy them. There's no joy in this. There's no excitement. So the reason I say this is an important one to look for, because sometimes when someone is no longer able to enjoy things, they don't do them anymore. So maybe one of the things they've enjoyed is going to their faith community, worshiping, going to worship services or social gatherings, and they're not showing up any longer. Or you see that they seem to have lost their enthusiasm, their ability to really enjoy. So that's a key symptom there. The third symptom is, and this sometimes, the way it goes surprises people. So we talk about a significant change in weight or appetite. And for people who are seriously depressed, that's very likely to be a decrease in appetite and thus a decrease in weight. Okay, so why is that? So what you may find is that, one, food has lost its appeal. There's just nothing that really tastes good, looks good to you. Second is, you don't have the energy to fix a good meal, a healthy meal. And maybe third, you don't want to go out to a restaurant. And so what you end up doing is just doing the very least you can to sort of survive when it comes to eating. Now, some people do gain weight, and that can be a case. But really, you look for it either way. But, especially when you see someone who has lost weight, that could be a sign that they're going through a depression. The next symptom is a change in sleep patterns. And again, may be surprising to hear that in terms of sleep, very often it is a disturbance in being able to sleep. Okay, it's not so much sleeping more, but actually sleeping less. It doesn't mean they're not trying to get sleep, but what you may find is they have trouble getting to sleep, often reporting, I tried to go to sleep and all I could think of was these terrible things going on in my life and about me and my future and my circumstances. And then they finally fall asleep, but they also might wake up an hour or two earlier than normal and not be able to go back to sleep. Now, some people sleep more, and then sometimes you just see people spending more time in bed trying to get rest, but they're not getting the real quality restorative sleep that's so important. So it's not surprising, then you'll see the next symptom here, is the person has fatigue or loss of energy. Everyday tasks that used to be you could do effortlessly, now they seem overwhelming. And you don't have this energy, the strength to do these things. And so, you just find yourself falling farther and farther behind, and the chores seem to mount up. Also, what you're likely to see here, the next symptom, is being slowed down. And that could be it can be physically slowed down in terms of how you move, but it could also be your speech and thinking. And so the person may walk more slowly, show much less, activity, but also talk more slowly. Conversations are slowed down. Now, there can also be, as you see, restlessness. There can be periods where a person will feel very restless, agitated, anxious, find it difficult to even sit still or stand still. Very, very painful thing to be going through. Next symptom is difficulty thinking or concentrating or making decisions. And often, what you find is that the person who used to be able to enjoy reading books, reading newspaper articles, they find that they cannot stay focused and concentrated enough to actually make it all the way down a page. Okay. And they may have trouble even focusing in on a conversation with you. And so this can show up as, but I told you something, but you never heard it. Because you only heard the first few words of that conversation. And then you see here the indecisiveness, just to making some very basic decisions, what to buy at the grocery store, what to order at a restaurant. Those things seem very, very difficult. Another symptom, and this one I sort of alluded to earlier, is these feelings of worthlessness or extreme self-criticism, or guilt and hopelessness. Excuse me. So, or what we sometimes talk about as self-attitude, the thoughts and feelings about oneself. And so somebody who has in the past felt good about themselves, felt like they can accomplish things and they're respected, now they find that they feel like a fraud, an imposter, that they were never that person, and they've been fooling people. And so there's this tremendous focus on all that is wrong with you. And then last here are frequent thoughts of death or suicide. And those thoughts of death can come different forms. Certainly thinking of suicide when somebody is thinking about wanting to end their life, to actively take steps for that. But sometimes you find depressed individuals, have a more passive death wishes. They would not take that step, and yet they wish that nature would sort of run its course and take them away from this painful life. So those are 9 symptoms. And on the next slide, you'll see basically how the determination is made. So if you find yourself experiencing any of those symptoms for a period of at least 2 weeks, then you really might want to talk to someone, your primary care provider, or mental health professional. As you talk to them, they will try to determine exactly how many of the symptoms you've had, and have you had those for every day, almost every day, for a 2-week period. So that's the important step. We want to give our volunteers that we recruit this sort of information so they'll know how to pass it along to others, and then what to do if it does look like they might be depressed. And so there, Dr. Antoine can guide us.
Thank you, Dr. Hale. I think those pieces of information are always important to repeat. And one of my mentors a long time ago talked to me about the importance of looking at the content and the process of anything that a person is going through. And I think that what these symptoms and the culmination of those symptoms in what we call major depressive disorder is looking like is really the content. Looking at these criteria and getting a sense of what does it actually look like when we would call it a major depressive disorder, and what does it look like when it's truly impairing a person's daily functioning. And that's why it's always good to repeat those symptoms. Part of what I'll go into, and also Kimberly will go into after me, will be the process of what happens when these things are identified, because it can take some time for a person to get to that point of saying, things are difficult and I need to get some type of assistance or help with what I'm going through. And it brings up the relevance of what CDAP, the Congregational Depression Awareness Program, is aiming to do to make that process a bit more straightforward. So first to think about it is, once a person has thought to themselves, I need that help, there are treatments that are available, as Dr. Hale said. We often think of psychotherapy as the first way to go, because there are a lot of things that can be talked through to help adjust to the situation that is overwhelming or difficult for a person, especially if they're having changes in their life that could spark a increase in depressive symptoms. Obviously, during COVID, there's been a lot of things that have been stressors, whether it's the illness itself of COVID or social changes that have happened, either loss of job, loss of family members. Various adjustments can occur where psychotherapy is essential and very helpful to reshape or reframe how a person can adjust to this new way of living. And if that is not fully effective, there are other things to go along with psychotherapy. Medications can also come into play, and there can be a wide range of medications used. There could be even a whole talk on biology of those medications, but the goal here is to say building a menu of options that can help with depressive symptoms, especially if it gets to the point of impairing a person's ability to function on a daily basis. That's critical to think about. So, psychotherapy is a good way to touch base and talk through issues and reframe and restructure how a person may shape their life because you may need a new routine to adjust with depressed symptoms. And that might be different eating patterns, different exercise patterns, also different social supports to make sure that a person has enough to lend to success in the future for them. And the medications themselves can have ups and downs. Some medications are effective for depression, but there are also potential side effects for that. So it's often advised to not just stick with the medication and say, it's going to work, but talk through with whatever practitioner you're working with to decide whether it's helping you and whether there are side effects that could be adjusted. Some medications, for instance, have difficult side effects that people deal with, like sexual side effects or weight gain, but there are often alternate medications that can be helpful. And if there is awareness of also what that may have worked for other family members, if there's a family history of depression, there could be a tailoring of treatment to ensure that it's the right fit for a person as an individual rather than just going with the medication and pushing that forward. So I would say the combination is very important, but the other part of this is also critical because we want to make sure that or a person or a practitioner, whether it's a psychiatrist, now it's more nurse practitioners, primary care providers, helping out with this process as well, in addition to therapists of various types, we want to make sure that it's working. So making sure that that ability to function on a daily basis is getting better. And without that, it probably needs to look for different aspects or layers to what is added. And I use that term layer often because when I encounter individuals who are coming to therapy and psychiatric treatment, a lot of the times they are individuals who have not encountered mental health treatment before. So I've started to use this paradigm of Bob Ross, which I think many people are familiar with, but it sets the stage for a lot of different aspects to say we want to make sure, practitioners should make sure that all the aspects of the individual are understood, almost like painting a canvas. And it's not going to be done in 1 hour or half hour, but over time, a practitioner should be making sure that all the different aspects, whether it's the trees and the lakes, are being painted in detailed layer as a practitioner gets to know the individual coming in for treatment, because you don't want to miss the big mountain in the background, whether it's the loss of a family member or the grief that goes along with that, or a severe medical illness that might be readjusting a person's life. It's very important that there's a good fit with whatever practitioner is in place, and that fit allows for a richness of the picture. And without that, things might be missed. Because even with some of the content that we talked about, there are cultural variations to that. Self-attitude looks different in certain populations, such as African Americans, not necessarily saying they feel like they're not a good person, but more so they might feel like they're not accomplishing their social roles as well. And so these nuances are very important to understand so that the picture can be enriched, but also individualized to the person coming in. And within that, there are other nuances that may or may not be important to individuals. One of those in particular for this talk is faith and spirituality. Where does that come into play? Is that changing? Is that a layer that we should add or not add for that individual? But that's something that should be brought up in the one-on-one treatment setting to ensure that what's important to the person ends up on this canvas and gets tracked over time to make sure that a person can really engage in the things that are important to them. And why is that important? Why is this picture really important to frame and enrich? Well, it comes down to another image that often with depression, it can feel like pushing a rock uphill that's going to fall back on us. And that can come with the image of Sisyphus, where Sisyphus pushed the rock up the hill and then invariably it falls down. But the question becomes, what happens if we could raise or decrease the height of the hill or make the rock smaller? And that's an analogy to say that treatment can look at different aspects of what's going on in the person's life on that canvas. It can be therapy, it can be medication, but also it can be thinking about who else can help push this rock uphill. What is the social support that's available for the individual, whether it's a church member, someone that they hang out with, close friends or family, other persons to help things get a little bit easier. And then on the other side of that, it could be what things in a person's life might not be necessary at this time to make the hill less steep. Because the combination of all these aspects is important to look at the overall person. And medications, again, and therapy are going to be a piece of that. But social support often has been seen as the most important predictor of a person's success for any mental health issue, including depression. But I think the uniqueness of what we're looking at here with CDAP is, where does the church or the congregation or the religious background come into play? And that's something that we hope to evolve in terms of thinking over time. So again, I think the process is almost as important as the content of what we're looking at. And I want to give Kimberly some opportunities to talk about what happens when a person's engaged. What are the resources and options available to keep this process moving forward? So Kimberly, I'll swing it to you.
Thank you, Dr. Antoine, and good morning, everyone. And again, thank you for having us today. So I wanted to highlight some of the local and national resources that we have worked with very closely in implementing our program. They have provided some very helpful educational resources and material for our website, for our curriculum, and also some services and resources and support for our CDAP volunteers and their communities. So one is Substance Abuse and Mental Health Services Administration, also known as SAMHSA. They are a confidential, free, 24/7 information service for individuals and family members facing mental and or substance use disorders, and they provide referrals to local treatment facilities, support groups, and community-based organizations. So I do have all the information written here. Hopefully you'll get access to these slides here on how to access them as well. If you're looking for a treatment locator or center or a physician or clinician, you can use that website there. And of course, NAMI has been a very helpful resource to us, not only just Maryland, but to the Baltimore metro area. As you probably have heard, as you attended yesterday and today, they have many, many wonderful resources, including their family support group, their connection recovery support group, their peer-to-peer, family-to-family, and specifically that we have used their NAMI in our own voice program, in which there are presentations that provide a personal perspective of mental health conditions. And we have had one in particular that has shared her story actually for a video that we have on our website. And she is an amazing speaker. And it's an excellent resource for our CDAP volunteers who can join sessions and events that they're organizing. And I'll actually share that in my next slide or two. And also the NAMI helpline here that I've listed. Pro bono counseling is a wonderful resource here for Marylanders. It connects uninsured and underinsured low-income Marylanders with compassionate and qualified mental health professionals who provide care on a volunteer basis at no cost. Again, pro bono counseling, they have provided numerous sessions to help us share their resources and support. A great partner for us as well. They developed the Warm Line that was developed at the onset of the COVID pandemic and have decided to continue that. So if you're feeling anxious, depressed, or just need someone to talk to, you can call that Warm Line. The Depression and Bipolar Support Alliance, the DBSA, they are focused on mood disorders, and they have over 200 affiliate chapters that offer peer-run support groups. They do offer a number of educational resources on depression, bipolar disorder, and a screening center. Last on this slide is the American Foundation for Suicide Prevention. They do educate the public about mental health and suicide prevention. They support survivors of suicide loss and those affected by suicide. You can find a local chapter on that website below, and also highlighting Out of the Darkness Walks, Out of the Darkness Walks, which they have held, I believe, starting within the last month or so. I'm actually participating next week in one in Columbia, Maryland. So on the next slide, National Institute of Mental Health, they do have a lot of information that we have kind of used our material, free information. They have expert reviewed information on mental disorders, treatments and therapies for specific populations and clinical trials. They have statistics on prevalence, treatment, and cost of mental illness for the population of the United States. Free, downloadable, and you can order brochures and fact sheets online and have them sent to you. The Mental Health America addresses needs of those living with mental illness and promotes overall mental health. They have, again, over 200 local affiliates in 42 states. They do offer a lot of education and research and information and referral services. Again, the website is there. And lastly, I wanted to mention the 988 Suicide and Crisis Lifeline. If you haven't heard of it, it was launched on July 16th of 2022 this year. Nationally, you may have heard of the Suicide Prevention Lifeline that has been a 10-digit number. It is still available, as well as the Baltimore Here to Help hotline, but we are trying to move over to the first ever 3-digit dialing code for suicide prevention in mental health crisis. So if you or a loved one or anyone that you know is an immediate crisis, please call 988. And I also listed some helpful websites to share information. You can download graphics, posters, cards, handouts, fact sheets to please share with your communities, congregations, neighbors, schools, anyone that you like to help promote that message. So next slide on lessons learned. So we have been working with faith communities, part of our Healthy Community Partnership, for over a decade. And one of the things that we have learned is the role of faith leaders. And faith community leaders are often the most trusted and respectful and influential figures in their communities. And they are often the first point of contact when individuals and families face mental health problems or traumatic events. So one thing that we did learn from the CDAP is when we were recruiting for volunteers, it was important to first have the support from the faith leaders. So when they were applying, we did ask for a letter of endorsement, and wasn't so much as a letter of recommendation, but just to really state two things. One, they support their member of the congregation to go through the training program. Two, that they recognize that depression is a condition no different than diabetes or heart disease, and it can be treated. And actually, three, that they would allow the opportunity for the volunteer to share information with their congregation and community. And second, we learn the value of lived experiences. Yes, statistics and coming here and sharing information about symptoms and risk factors is important, but we learn that the humanness is just as important, or if not more valuable. So we have gone and, both Dr. Hale and I have shared some personal perspectives with depression. And we've also, as I mentioned, NAMI in our own voice, to hear those personal stories will help folks to more open up and feel more comfortable to talk about their own mental health experiences, whether they're directly impacted or impacted by loved ones, because chances are we all have been impacted, whether someone we know or someone that we in our family or someone we've experienced ourselves. And lastly, extra support needed with materials and resources. Sometimes it can be very difficult for congregations to, yes, we can send websites and links. It can be hard and challenging, particularly financially, to have those printed, particularly when it's numerous copies, because a lot of congregations, particularly here in Baltimore, are very large. So for the toner, for the paper, to print off 50, 100, or even thousands of copies can get very expensive. And so developing handouts that are specific for CDAP on depression and to provide them with easy access is key to help promote the depression awareness program. Pass that along back to Dr. Hale, I believe.
Yeah, thank you, Kimberly. And the three of us can all speak to this. But another lesson learned that sort of is pointing the way for us is that the enthusiasm and the interest in this program exceeded what we had expected and what we even hoped for. We were fortunate to receive a foundation grant to get this launched a couple of years ago. The grant said that we would train 20 people and sort of see where we could go from there. What we found was there was so much interest that we ended up doing 4 cohorts of 10, approximately 10. So we ended up training 40 individuals, and their level of enthusiasm has just been so gratifying. Another hospital heard about this and has replicated the program, Howard County General Hospital. So it has given certainly me, and I think Kimberly and Dr. Antoine, confidence that this is where we should put more of our energy. So this has been largely the Baltimore area. We are now beginning to think about and prepare how we can take this elsewhere to other parts of the state and even beyond that. So Dr. Antoine, Kimberly, other things you'd like to add to that?
Yeah, I would. I think the enthusiasm is very clear by the number of participants that we've had so far. And I think we are in a stage of mental health care and behavioral health care where going outside of the hospitals and having the people come to the practitioners is going down a little bit. And this is representative by us going to the congregations and the churches. And I think there's an opportunity in the future to consider which congregations are we going to. Are we talking about Christianity alone, or are we talking about other types of religions and backgrounds, and how do we reach them, and what is culturally appropriate for their processes in terms of those religions and spiritual backgrounds? But this is a template for, I believe, the future of healthcare, to make sure more people are aware, so they can seek out the resources that are appropriate, and could also imagine other types of settings where social acceptability of these types of discussions needs to be fostered. And that's something maybe in future years we can get to. But Kimberly's points about the resources needed is a key one, in that to fortify this for sustainability, we're going to have to think about how to staff this properly, and how to make sure people truly are impacted in the way that we hope, which is awareness, but then reaching the care that they need to get past these difficult situations and these difficult times. But I know I've shared a lot of excitement and put my time towards this, because I see this going in great directions in the future.
And I just wanted to add that, mental health and depression has always been an area of concern, but with COVID, it definitely has heightened with, isolation and a lot of fear and anxiety. And there has always been there's never a bad time to talk about it, but this has been even a more reason to talk about it. And two, there's still a lot of stigma, and it's definitely more open to talking about it, but we still have a long ways to go. And so this is just one program that I think that really addresses the need to address depression, but also to reiterate that depression There is treatment. You're not alone. There is help out there. And that's what we're here to do, to help that awareness and let people know that there is help, there is support.
Yeah, and I want to pick up on something Dr. Antoine mentioned right at the beginning, talking about sort of the care and recovery. And for me, I grew up in the church. Church has always been a part of my life. And a term that we used early on, I've always heard, is the church family or church home. And that really meant something in my family, particularly when we moved to a new community and my mother and sister had polio. And it was people that we really hardly knew that stepped in and supported us. And I think that's so important when it comes to depression and other mental health conditions. Like Dr. Antoine said, we have some good medications, and psychotherapy in combination are really helpful. But also point out that, let's say you get the medication, which is probably going to take several weeks to really have the beneficial effect you want. And you see a therapist, maybe even if you're fortunate, once a week. But there are 167 other hours in the week, and so you can't just sort of live on 1 hour a week. How helpful it is when you've got others who understand what you're going through, or at least really want to understand and will listen to you and can provide that support and reaching out, keeping you sort of emotionally afloat until the medications kick in better and the therapy takes effect. So there is such a huge role here. And Faith, as Kimberly mentioned, she and I and some others here at Hopkins have worked in this field beyond mental health for so long. And faith communities are just this wonderful resource. And so we just really want to sort of educate, equip, and empower volunteers from faith communities to really have that impact on their fellow congregants and others in the community.
So I think from here, it seems like a good opportunity to see if there are other thoughts from the team. But I'm again happy to be part of the conference today, and look forward to hearing what people are wondering about.
Yes, thank you so much for such a great presentation, folks. We would now like to open up the workshop for your questions. If you have any questions, please post them in the Q&A at the right-hand side of your screen. And if we don't have time to answer your questions today, please send your questions and the name of the session you attended to connection@namimd.org, or you can also submit your question in your end of event evaluation later this afternoon. So I'll be checking the Q&A section now, and I'll read the question so everyone can be on the same page. We have lots of compliments for the team, great information for mental health. We also have a question there. Could you please share the contact information for your programs, POCs in Howard County?
So I did respond to Juliet directly, but I can put my email in the box. So if anyone has any other additional questions that we don't answer here, you can feel free to reach out to me, and I can connect you with Howard County.
Okay. And I have a question. It seems like you've been answering a few folks, but I'll read the question just in case. Melissa asked a question. She says that she works in outpatient palliative medicine, where there's a lot of older adults who are homebound. How does this program offer any type of in-home support?
So I'll speak to that briefly. Maybe Kimberly or Dr. Antoine will add some more. One of the, I think, beauties of the program is that we provide the basic information and resources, but then the volunteers, in consultation with their faith leaders, can take that and tailor it to whatever they see as the greatest need. And so one congregation has developed a support group. Others have handled sort of providing programs, educational programs in the congregation during worship services or immediately after, so forth. But I think, it's the sort of the core resources and information, and then you can take it and run with it. So, I can certainly see where some congregations would want to have a special interest reaching the older adults who have been isolated. Congregations generally have a large membership of older adults and sort of a history of volunteering to support them. So I think the information and training that we provide could be utilized if that's what a congregation sees as a need they'd like to address.
Thank you, Dr. Hale. Appreciate that.
And I would add to that, I think this is part of the process that we'll be building over time. And what are the resources that we should equip congregations with moving forward? Kimberly's list is a great one. And I'll start probably thinking of pieces that might add to more accessibility for individuals who are homebound, like mobile treatment options and things that might be technologically easy for people to adapt to, especially if they're older and maybe don't have as much technology access. So I think it's an opportunity that we'll have to capitalize on.
Thank you. It looks like we have a testimonial. Carolyn Harrison loves the program and shares how she has benefited from your work. So thank you. Another question from Maria comes in. Do you have any other ideas to help her homebound and aged community?
So, Dr. Antoine, I think you're ready to speak to that. Go ahead.
I would say that there are aspects to being homebound and aged that sometimes fall outside of the bubble of depression, but certainly can lead to depression. And it would be an opportunity to think about what other resources could help out there, whether it's some type of occupational therapy approach that could help structure a person's day. And that often leads to different behavioral health care options, such as the mobile treatment that I was mentioning, making sure that there's an eye on the bigger picture, as I mentioned with the canvas. So depression can be part of that, but what I've seen with some of the individuals that I've worked with is there's a barrier towards a person getting out and getting meals. So Meals on Wheels could be an option to help with that. So the first piece would be having a person who can sit down with that individual. Hopefully it would be a primary care doctor or someone who could be the captain of the person's treatment to say, what are the barriers and how can we address that? In this day and age, case managers for insurance companies often end up being that person as well if they're linked in. So I would try to figure out who that captain is, but either a case manager or a primary care provider could be helpful to paint that picture and then identify the resources to get a person more connected to the community.
Thank you, doctors.
Yeah, let me, if I can speak to that too. I think another layer that can be done, one of the things when you're talking about someone who's depressed, it may be easy, and you recognize that someone has shared with you to say, well, please call me. Let me know if there's anything I can do. Most depressed individuals aren't going to take that step. They don't have the energy, the initiative. They feel guilty about taking your time. So, part of this is to take the initiative to say, I'm going to call you every day. And then they might say, you don't need to do that. And I say, I know I don't need to, but I want to. I care about you. I love you. I want to do what I can. So I'm going to check in with you every day. And we did a survey of about 100 individuals who have gone through depression. We said, what was it that sort of kept you going? And what did people say and do that helped? And it was that sort of people reaching out to them, taking that initiative, sometimes insisting on dropping by, just to check in on them. So I think there are a number of things that can be done. And certainly if you could get, like Dr. Antoine said, get somebody to really head up that team and coordinate so that, it might be 3 of you or 4 of you, share the task of who's going to initiate, who's going to do food, so forth. If you're depressed, you don't feel loved, and to see people who really do show they love you, they care about you, that can be valuable.
And if I could share one other example to that, part of our curriculum on effective listening, particularly if you're a member of a congregation and you notice that someone has not, maybe who regularly attends and has missed a couple services and you haven't seen them around, give them a call and say, we haven't seen you for a couple weeks. Is everything okay? And kind of sense, how they sound and how they feel, and what, not necessarily just congregations, but if someone's like part of a support or some kind of group, senior group or whatever it may be, and they haven't attended regularly, check in on them, and just to make sure they're doing okay.
Thank you. Another question came in, and I'll reframe it a little bit, expand it. Any recommendations for the Latino and other immigrant communities with how to implement this program?
I think that's a great question. And I think that's a question for the field in general for mental health treatment. What is the most culturally appropriate way to make sure that we're in that space and meeting the needs and specific needs of things that might be addressed with changing of locations and even other cultural barriers that make it difficult. Finding Spanish-speaking practitioners, I think, is the biggest barrier there. And I think that's something that SAMHSA is working on, and some of the resources that Kimberly's brought up to have some Spanish-speaking processes there. But I think that if I'm reading the question a little bit more, in terms of insurance and pieces of that nature, there are some pro bono counseling services like Kimberly talked about, and I've noticed that some of the Department of Health in the area, this is for Baltimore region, are starting to think more about this and provide more resources. So I would say that's where the state-funded resources would be a good place to reach out to if there's a lack of insurance, because you might have more options there. But this does seem to be an increasing focus in many areas.
And let me add, if you could, Maria, I think was the one who asked about that, if you could sort of reach out to Kimberly with your email, we can probably connect you with a program they're trying to get started. They will be getting started at Sacred Heart of Jesus, which is sort of a home parish for the Latino community in Highlandtown. And so they might have some resources.
Thank you, doctors. She adds that in Southern Maryland, where she's from, it's very hard to find help for children and youth. So thank you for the ideas. I guess that's another target population. A lot of times we think about faith communities in terms of all the adults. However, children also can suffer from depression. And is there anything specific for the youth groups inside of communities of faith we can talk about?
I think the thing to keep in mind is that certain aspects of the younger population can be more prone to thoughts of suicide. So I think from our standpoint, awareness is the biggest piece to bring up and make sure that congregations are aware of, so that the pastors and the persons who are instructing and guiding the youth can check in. As Dr. Hale said, when you're checking in with someone who's depressed, it might look like a different type of check-in for someone who's younger. Maybe they're showing up but a little bit more withdrawn because their parents brought them there, or they're not as prone to talk with people. And having activities to have some type of check-in when they do show up and adjusting that would be the best way to think about it. I think that's where the community and being present and aware is going to be the most important piece.
There seems to be some intersectionality also there with youth psychologically, maybe with the guilt and shame and pressing up against your faith and questions about your faith. And when you add the third piece of that, whether if it's an immigrant community where you're a newcomer, there seems to be a lot of intersectionality that congregations will have to talk through, huh?
I'd agree with that, and I think it's providing a space for those conversations, and making sure that the congregations recognize that maybe that needs to be created. And it's not part and parcel of just showing up to the church. And that's part of the awareness that I think comes with these processes and the program we're trying to build up.
Thank you. We have a few more minutes if anybody has any questions. Let's see here. We have a question about LGBTQ youth. Have you seen any? Have you seen that question arise in your work, LGBTQ youth and faith communities?
I haven't seen that. We have not had the opportunity. I think that's a good point. We know that LGBTQ youth have higher, more common to find thoughts of suicide, and to have more mental health concerns, because it is very difficult to be different and to not feel included in your school or social network. So that's it's an important thing to address, and I would welcome an opportunity to do something along those lines.
If I put in the chat box, so the Trevor Project works with LGBTQ youth for mental health services. So I am familiar with that resource, but I can certainly look into other services.
Well, thank you, Kimberly. I didn't realize that was you.
I think it points to what you said about intersectionality, that there's so many facets of how this can be looked at, that we need to probably keep track of resources along those lines. There can be congregations that have a high degree of persons with substance use disorders in the congregation, or high degree of veterans, African Americans, LGBTQ. Different aspects bring around different foci. You mentioned the immigrant population as well. I think the key here is going to be having an adequate network to address and equip these congregations to go to somewhere where it can get the help. And Kimberly's done a great job of being that catalog. And I think we need to make sure we add to that as we learn more.
Thank you, Doctor. So last couple of minutes, I'll give you some time to ask one or two questions to get it typed in, or I can allow you to reclaim your time and take a mental health break before the next session. Okay, well, before I officially close it out, would the panel like to add any final thoughts or pearls?
I would just say that, and we've mentioned it a couple times here, we're still learning. And so, please, ideas you have of how we could reach more, or, what are some of the needs out there, please feel free to reach out to us, and we can learn from you.
That's right. That is the beauty of the NAMI community. We are a community, and we feed into each other and make things better.
And I just want to congratulate and compliment NAMI on all you do. You have been such a great partner with us, and we wholeheartedly endorse NAMI and do everything we can to support you, because you're so good supporting us.
Likewise, I know you've been speaking into the faith question for quite a few years. So thank you for coming back and continuing to answer that particular mail, and so that folks in that community can feel included and also have additional information and education. So we appreciate that. Juliet says, excellent presentation and thank you. In my closing remarks, I'll say that we are so very thankful for so many people that have joined us today. It looked like there was about 20 folks or so on the line. And at the end of the conference today, you will receive a link for an evaluation survey. And